very much. I would just use 2 minutes to also to say that according to our study of combined treatment regarding ND progression in LCH pediatric patients, we do not observe, since the clone is cleared from the bone marrow, we do not observe such correlation with progression to ND later on. So we would like to publish that, but the connection with Moscow is now a little bit difficult, so hopefully we will do that. So thank you very much. I will speak about targeted therapy of pulmonary involvement pediatric LCH. This is pretty much the update of what we were doing for several years now. Just to quickly remind that adult and pediatric PLCH they're different, they're not the same. Usually pediatric pulmonary LCH is connected with multi-system disease and usually presents along other symptoms, usually clonal. And lungs are not risk organs anymore since LCH3, which showed that in general that the independent contribution of lung disease is not this important. However, in recent settings, as we are very, very eager and we are very good at treating MS RO plus disease, that could be in general reconsidered because we are now controlling the disease very, very good. However, what we see in populational studies that patients can still suffer from irreversible lung damage and consequently die. This is a very, I love to refer to this paper because I think this is a very good study by Selene and the team. The pathology of PLCH is quite complex with what we know is the pericentric inflammation with the destruction of the walls of the bronchi and the subsequent appearance of cysts. And what we know from the genetics is that V600E is rarely observed in pulmonary LCH, and it's more of BRAF 12 exon mutations. However, MAP2K1 is also present. And this is the paper from the Dutch group, and we more or less confirmed that with our own Moscow local study. So currently, pediatric PLCH is not a high-risk LCH. The standard of treatment is the same for other types of LCH, including limited bone lesions. So this is a little bit tricky because you have one scheme that one size fits all thing. Patients may suffer from irreversible damage and subsequently require lung transplantations, which is suboptimal. And BRAF V600E mutation is less common. Since we already have 15 years since this inhibitor era, BRAF era in LCH, and for sure there are different indications for the targeted treatment, and lung involvement is recently new one, but quite important. And this is the case of 18 years old patient with pulmonary involvement who was treated with trametinib with significant but yet not dramatic efficacy. We know that in patients with risk organs involvement, we usually observe a dramatic, very, very quick efficacy. However, in lungs, this is the different story. And we decided to see how specifically targeted treatment affects the lung, the pulmonary involvement in pediatric LCH. So basically, the inclusion criteria are quite understandable, and the exclusion criteria would be less than 6 months of interrupted targeted treatment and less than 2 scans available, so we need to evaluate. We now have 15 patients included. We're analyzing the scans, so this is the study in progress now, hopefully we are getting more and more now. This is quite exciting because we now tend to see more severe, exciting for us, not for patients for sure. We tend to see more severe lesions and tend to see more based start of the targeted treatment. And I think that that's going to show what it really can do to the lungs and to the patients. Patients are from 8 different countries, 15 patients, and we excluded the patients with lung involvement is not suggestive for LCH, so sometimes this is just a consolidation that couldn't be scored according to lung involvement scoring, which is basically the separation of each, so for fields, and then in all, it's gonna give up to 24 points for each lung, and the sum from cyst and nodules can be 48. So basically, this is a short cohort characteristic. This is predominantly male patients, predominantly multi-system. One single system. In KGB, they say that if you're not in jail, that's not you overachieving. That is we underperforming. So basically, here probably it can happen that the patient had single system lung LCH, but usually we see that in a multi-system context, and sometimes probably we can miss some specific points and specific sites of the disease. And usually, interestingly, these patients were risk organs negative. So this is also an interesting fact. We will come back to that a bit later. So once again, BRAF V600E is not a predominant mutation. We say other, but they include MAP2K1, they include 12 exome deletions, and others because sometimes they just test for BRAF V600E and do not do more wide screening and testing. Inhibitors used for 4 BRAF V600E positive patients were used specifically, BRAF V600 inhibitors, but for others, this is predominantly carbimetinib, but trametinib was also used. And usually this is either first or second line of therapy in severe cases. And now teams and doctors tend to use this more in critically ill patients as a first line. Median age at diagnosis was 8 months, and at inhibitor started 18 months, and patients were mostly rather ill with 7 points median disease activity score. This is also an interesting thing that we've observed because these patients tend to have pituitary stalk and thyroid involvement, which you do not often see in LCH patients. This is so pituitary stalk, yes, but in our cohort, about 30% had DI and other symptoms and signs of pituitary stalk involvement. Thyroid, for patients, also not that is being quite oftenly observed. What we see is quite predictable to say, but it's good to observe that therapy is effective, but it usually takes time, and usually it takes a lot of time to heal the cysts. Nodules respond to therapy quite fast, with coming to null approximately after 1 year of treatment. But the cysts, usually this is more than 2 years, sometimes this is 3, 4, 5 years of treatment, which would result less damage. So basically, this is connected to the natural lifespan and the natural course of the disease, because to heal cysts, you basically need just the time for lungs to restore. This is not just the same that we observe, for example, with skin, when you just can control these cells and everything is gone. So this damage it takes time to heal it. This is just the what we observe. This is quite in line. So you see this big cysts are getting smaller. The lung tissue tend to heal, to restore. But in general, it usually takes time. And then in 2 years, you still can see rather big cysts. So we hope that that's going to heal over time. But the thing is that it's not healing in a moment. Sometimes we observe the severe cases. For one of the patients from the study is the patient who underwent lung transplantation. And in this case, this is quite understandable because 6 pneumothoraces happened, left side, right side, bilateral, and one last leading to cardiorespiratory arrest. So in this setting, for sure, you need to act. And probably for this patient, that would be beneficial to start earlier. However, this is just the time at which the disease was discovered. However, now we have a patient in Poland. This is the 4 years old girl with spontaneous pneumothorax as a disease onset. The involvement is lungs and diabetes insipidus. She was on the strict parameters for artificial ventilation for several weeks, and the team was hardly considering lung transplantation. We've discussed that and decided to start with MEK inhibitors and vinblastine. Vinblastine was the desire of the team. And we will try now to see. The progress is not that big. However, this is the initial picture. Yeah, probably not too much. With a lot of drainages and the patient being in ICU for 10 weeks. And at that point, we've started the therapy. And this is what she has pretty much now, 1 month ago. The thing is that it's not a big improvement on a CT scan picture. However, from the clinical side, we see a huge improvement because the patient is without, so she's now extracting the drainages one by one, but she's now only on a oxygen datation from the mask without artificial ventilation, doing good. And the thing is that, in general, it appears that the clinical status is recovering. And what we will probably see in the future, hopefully, that as other patients, she would recover from this tissue. She will recover and get better with a lung function. And this shows that probably we can, in such cases, we can win time with starting an inhibitor and then just going with the only inhibitor therapy just to wait enough time, to give enough time for the lungs to restore. And in that case, we can later consider other treatment options or just let it go with the inhibitor. Because lung transplant is something that we eventually do not really want to do. Usually the problem is in insufficient donor availability, things like acute rejection, chronic insufficiency, high risk of retransplantation, and another thing is the need of pre-transplant disease control. When we say that when we cannot address this very, very good because the screening, so as you see, BRAF V600E is not an issue, and in a critical situation, it's hard to say if the disease is there or the lungs are just so damaged. There is no disease, but the damage is irreversible. So I think that in such situations, we can consider starting inhibitor and just watching what's going to happen and support the current lung function. So we see that the therapy is effective for the treatment of pulmonary LCH. The nodal components react much earlier. Cystic component is can show the result years after. And in severe cases, inhibitors may act as salvage therapy, stabilizing the disease and giving time for tissue to recover. And there are for sure a lot of outstanding questions. How does previous treatment affect the speed of lung restorations? What input has BRAF 12 exon mutations of BRAF? Why that is more an issue for the lung disease? Is there a difference in different inhibitors and the efficacy? When is the optimal starting time for the inhibitor application for this treatment? And how should clonal eradication be achieved and controlled? For example, if we give time for lungs to restore, what we should do next? Should we apply chemotherapy or should we combine? Or, yeah, a lot of questions. And there are reasonable doubts because the cohort size and study design is so more retrospective, and the inclusion criteria are retrospective. This is non-universal timing for the scans, and this 2 years mark, and after this is sometimes hard to compare. Operator-dependent scoring systems, no comparable data from the conventional treatment cohort because that was never a specific isolated issue, and reluctant natural course of the disease. So with that, I'd like to thank the whole French team for their input, for their help, and yeah, thank you. Merci.